How exactly do you put a price tag on human life while still ensuring the absolute highest quality of care? Welcome to this explainer. Today, we're diving right into this really complex, high-stakes dance between clinical excellence and the bottom line. This isn't just some abstract debate, right? It's the everyday reality that hospitals, doctors, and nurses are facing on the floor. Understanding how we evolved from a super fragmented system to one that's laser-focused on value is absolutely fascinating. So let's just jump right in. We actually need to start with a number that completely shook the medical world, and that number is 98,000. Historically, we were seeing up to 98,000 people dying every single year in the US from totally preventable hospital errors. When the landmark 1999 report to Err Is Human brought this to light, it hit the industry like an absolute earthquake. To put that into perspective, it's literally the equivalent of a jumbo jet crashing every single day. So this wasn't just a grim statistic. It was a massive, urgent wake-up call that our status quo was deeply broken, fundamentally unsafe, and just desperately needed a massive overhaul.
Here's a quick look at our roadmap for today. We'll be looking at 1. The healthcare quality crisis. 2. Strategies for improving care. 3. Systems and nursing leadership. 4. Shifting volume to value. And finally, 5. Measuring impact and cost.
Okay, let's start with Section 1, the healthcare quality crisis. For decades, we faced this staggering problem, where the system actually paid for medical errors, like it was just a normal cost of doing business. Seriously, if a patient fell or got an infection in the hospital, insurers just covered the extra treatment costs, no questions asked. To stop this, the National Academy of Medicine had to establish a brand new baseline. They defined quality not just as some corporate buzzword, but as the degree to which health services increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Simply put, care has to be intentional, outcome-driven, and strictly rooted in evidence.
Moving right along to Section 2, strategies for improving care.
So how do we actually take that super high-level academic definition and make it work in the real world? Well, the landmark 2001 report, Crossing the Quality Chasm, gave us a blueprint for exactly that. It laid out 6 crucial aims to bridge the massive gap between bad outcomes and ideal patient care. It said healthcare absolutely must be safe, effective, patient-centered, timely, efficient, and equitable. And guys, this was a total paradigm shift. Think about it. Timely means no more sitting around for hours in distress, and equitable means the quality of the care you receive doesn't magically change based on your zip code or demographic.
By really zeroing in on these aims, the expectations for patient care fundamentally shifted. Minimizing waste to tackle efficiency and actively avoiding patient injury to tackle safety basically became the new non-negotiable foundations of practice. We finally moved away from just reacting to illness after the fact and started shifting toward actively engineering a flawless, ground-up care delivery system.
Now, how do you actually implement these massive aims without totally disrupting daily care? Well, on the hospital floor, teams rely on the Deming or Shewhart cycle, which you probably know as PDSA, Plan, Do, Study, Act. It's this great successive cycle where you test small changes on processes, study the proof of concept, and then act on it. Think of it like testing out a brand new hand-washing protocol in just one single hospital wing first. You analyze the results, and if it works, then you roll it out facility-wide. This makes sure that small, safe tests lead to targeted, massive improvements without totally overwhelming the staff.
All right, Section 3, Systems and Nursing Leadership.
It's really important to remember that these improvement frameworks absolutely do not work on autopilot. They require highly competent leaders actively driving them right there on the front lines. Recognizing this, the American Association of Colleges of Nursing established core competencies for professional nursing education. They specifically highlighted how quality, safety, and systems-based practice have to be the core values of everyday nursing. Nurses aren't just taking vitals and following orders anymore. They are proactively coordinating resources and leading within incredibly complex systems to make sure that safe, equitable care actually reaches the patient's bed. To really anchor this all in practice, we can look to healthcare pioneer Donabedian. He broke this down into 7 distinct pillars: efficacy, effectiveness, efficiency, optimality, acceptability, legitimacy, and equity. His brilliant insight here was that you can't just look at whether a patient got better, you have to measure the entire machinery of care. He defined quality as a function of structure, process, and outcomes. So having a state-of-the-art ICU, well, that's your structure. Administering the exact right medication is your process, and the patient surviving, that's the outcome. You literally have to measure all 3 together to truly control quality. Which brings us to Section 4, Shifting Volume to Value.
Let's follow the money for a second, because all these amazing clinical frameworks couldn't fix what was basically a fundamentally flawed billing system. Take a look at this comparison. Under the old system on the left, fee-for-service, hospitals were paid purely for volume. They got a check for every single test and procedure, even if a patient developed a totally preventable pressure ulcer while in their care. It's crazy, right? To fix this, the Centers for Medicare and Medicaid Services aggressively shifted to the model on the right, value-based purchasing. This transformed Medicare from being just a passive payer of claims into an active purchaser of care, literally linking payment directly to performance.
These new value-based programs completely flipped the financial incentives on their head. They reward providers with incentive payments based on three simple but incredibly powerful aims: better care for individuals, better health for populations, and lower cost. Suddenly, a hospital actually makes more money by keeping a diabetic patient healthy at home than by amputating their foot in the operating room. Financial success is now inextricably tied directly to patient success, which is a massive win.
A really monumental piece of this whole economic puzzle is MACRA, the Medicare Access and Chip Reauthorization Act. This federal law officially killed those old volume-based formulas for good. It replaced them with a comprehensive new reimbursement system called the Quality Payment Program, which effectively forced the entire federal healthcare apparatus to finally focus on value.
MACRA streamlines provider reporting into two main paths. You've got the Merit-Based Incentive Payment System, or MIPS, and Advanced Alternative Payment Models, or APMs. By giving providers these two distinct paths, it essentially creates a sort of choose-your-own-adventure for doctors and hospital networks. It gives them super clear, actionable ways to figure out exactly how their value and quality will be measured, reported, and ultimately compensated, all based on the specific populations they're serving.
Finally, let's hit Section 5, Measuring Impact and Cost.
So how do we actually evaluate if all these financial and clinical solutions are working in the real world? Well, because we operate with severely finite budgets, we rely heavily on cost-benefit analysis. This is a rigorous process of weighing our healthcare expenditures against their possible benefits. It is absolutely crucial for setting priorities and determining access. When really tough choices have to be made about where millions of dollars are going to go, this analysis is what ensures we're getting the absolute highest possible clinical return on our investment.
And to actually calculate those benefits, we use one of the most fascinating metrics in all of health economics, the Quality Adjusted Life Year, or QALY. Invented way back in 1956, the QALY literally quantifies a treatment's value by balancing life extension with the actual quality of those extra years. It doesn't just ask if a treatment keeps someone alive, it asks if it provides a life that is actually worth living. If a $1 million drug extends a life by 10 years, but those 10 years are spent in constant agony, the QALY reflects that harsh reality, helping policymakers figure out if it's truly the best use of our limited resources.
Which leads us with an incredibly important final thought to chew on today. As our entire industry completely transforms to demand value over volume, how will you use these tools, the PDSA cycles, the nursing competencies, the alternative payment models, to balance the scales of financial cost and true life-saving patient care? That right there is the ultimate challenge of modern healthcare leadership. I really hope this explainer has given you the foundational roadmap to meet it head-on.